So I'll just let you read this quote by Rudolf Virchow. And that's very, very true in Nepal. I mean, I think, you know, we do what we can in terms of health care, but the most important thing is to have clean air and clean water to prevent diseases from occurring. And at the bottom, Dr. Cornea from UBC runs arts contest in the cardiology block. And this is the sculpture that one of the students did. She's got the Nepali flags and the heart, and then the topography of Nepal. And then she's got like two hands holding the world. So, you know, what happens in any part of the world, I think, can affect all of us. And I like the way she has the red nail polish on the fingernails of these hands. It's like women are holding the world in their hands. Women, I mean, the lives of both men and women are difficult in Nepal, but women in particular face a very high maternal mortality, like when they're pregnant and giving birth, because often there's no healthcare personnel to help with delivery. So the disease burden in Nepal, there's still a lot of communicable diseases because of the poor living conditions. TB is endemic. And then a lot of diarrheal diseases that kill many local people. So 50% of deaths are due to infections, maternal and perinatal problems, and malnutrition. So that's huge. But at the same time, there is, even though 80% of the people live in villages, rural environments, and 20% in Kathmandu and a few other larger towns, there is a migration from rural to urban, and people who live in the urban setting are a lot less active and tend to have more fat in their diet. So there are increasing rates of diabetes, hypertension, cardiovascular disease, and cancer in Nepal because of the shift towards urbanization. And this is the stages of epidemiologic transition. So initially, malnutrition and infectious diseases, when you look at populations as a whole, like developing countries, a few developing countries, not too many, but some of Nepal is in this category, where pestilence and famine are still major problems. So malnutrition and infectious diseases limit life expectancy to about 35 years. And not much death is due to cardiovascular disease. Most deaths are due to infections. And the heart disease that is seen at this stage of development is mainly rheumatic fever. And rural Nepal is still in this stage 1. And then there's receding pandemics. The stage 2 is receding pandemics with improved nutrition and public health. And chronic disease starts to become more prevalent because people live longer. And hypertension in particular becomes more common. Life expectancy increases to about 50 years. And there's more deaths related to cardiovascular diseases, especially hemorrhagic stroke from uncontrolled hypertension. And then Canada is kind of in stage 3, stage 4, where people live longer. There's more degenerative and man-made diseases because of the high fat intake in our diets, tobacco use. And then heart disease becomes common, causing 35 to 65% of deaths. And then finally we get to a stage of delayed degenerative diseases, and that's mostly where we're at. So we can certainly delay the development of heart disease by modifying risk factors. People live more than 70 years. And there's still, in Canada, ischemic heart disease and heart failure are actually now on the decline because of better risk factor modification and better treatment of heart disease. And cancer is still increasing, and dementia is increasing, because eventually you have to die of something. So coronary artery disease is becoming more prevalent in Nepal because of the aging of the population. People aren't dying at the age of 45 anymore. urbanization, decreased exercise, more fat in the diet, so that results in more higher cholesterol, salty diet, more hypertension, smoking and air pollution actually increases heart attacks as well as causing chronic obstructive lung disease. And South Asian people do seem to have a genetic predisposition to coronary artery disease as well. Very fatty foods. So we visited the National Heart Center in Kathmandu last year. And you know, it's a really well-equipped hospital, but it was interesting to see that most of their surgeries are related to valve disease, whereas in Canada, most of our surgeries are related to coronary artery disease, just reflecting how infection is still a major problem in Nepal. And they had cardiac catheterization laboratories and echo machines. They did procedures for arrhythmias, for rhythm disturbances, and some defibrillators. So, you know, they had a lot, but it was available mainly to people who could pay for it. So it's just a small segment of the population. And the equipment that they had was on par with what we have here in Canada. And it was pretty amazing to see some of the, they have a lot of congenital heart disease as well, because of the mothers, I think, often have infections during pregnancies, and that affects the development of the heart in utero. And their surgeons are very skilled at doing quite complex operations. And what I found is, you know, they really focus on where you get the most bang for your buck. So they're not going to operate, like we do the most for everybody here in Canada. And sometimes they're elderly people who have, you know, multi-organ failure already, and they're not going to do terribly well, even with all our procedures. But in Nepal, they would never waste money on someone who is unlikely to do well with the intervention. So sometimes I think we have too much in the way of resources, and they don't have enough. These are two cardiologists at the Heart Center in Kathmandu, and you know, they're kind of still seeing a lot of problems with rheumatic heart disease in rural Nepal, and in the city they're seeing more young patients with pretty malignant coronary artery disease, like diffuse disease in their coronary arteries. So different epidemiologic stages, some infection and some degenerative diseases. So the problem is that Nepal is really not well equipped to deal with non-communicable diseases. It's gotten better at dealing with infections. Vaccination rates have improved. But you know, to control infections, you really have to have clean water and clean air. That's kind of where you start off. All the antibiotics in the world won't help you if you keep you'll just develop resistant bacteria if you keep spreading infections in small groups of people. And Nepal is really poorly equipped to deal with an upcoming epidemic in non-communicable diseases like coronary artery disease that require ongoing medications and lifestyle modification, and then some high-tech procedures. So, you know, the WHO is recommending integrated systems to deal both with non-communicable as well as communicable diseases. So healthcare in Nepal is horrible in rural areas and pretty good in the city if you're able to afford it. So the doctor to population ratio varies a great deal. It's pretty good in Kathmandu, one doctor for 850 people, and then it's pretty horrible in the mountains in the Himalayas. So it's one physician for more than 100,000 people. So this medical school, the Patna Academy of Health Sciences, was developed to try to train physicians who will work in rural Nepal and address some of this inequity in healthcare. So the first class of students was admitted in 2010, and it's amazing how, you know, one person can actually make a huge difference. And this is Dr. Arjun Karki, who came to visit us in Edmonton a few weeks ago in mid-October. and gave rounds at the hospital. And he's a pulmonologist from Nepal, who did his residency training, some of it in the United States. And he's just a really, well, first of all, he has the big dream of improving healthcare. And then he's politically well connected in Nepal. And he's developed a circle of friends from around the world, physicians and basic scientists in different universities. And about 16 of us here at the University of Alberta are involved in supporting this medical school called the Patton Academy of Health Sciences. So he's just been really good at gathering people together to develop a sort of state-of-the-art medical school with admission criteria and problem-based learning and exams that are reflective of the best educational practices. So the Patton Academy of Health Sciences is attached to the Patton Hospital, which has 450 beds, and it's a large hospital. And it was first established in 1953 by the United Nations mission to Nepal during the cholera epidemic. And then more recently, it's become a government hospital. It has a very large, when I'm walking in the hospital, I'm always struck by the number of young mothers there are. It has a huge obstetrics department and a huge orthopedics department, because trauma is very common as well. And patients pay for the services they receive unless they have no money at all, and the nurses are good at assessing the financial status of patients. And if they have no money at all, then there's a charitable fund that will provide basic health care for patients in the hospital. So, you know, there's some pretty good services there, and I can only speak for echocardiography because that's what I do, cardiac ultrasound. And when I got there, the echo machine wasn't in use because one of the transducers had broken a few months ago. And, you know, they don't have money for a replacement, and it's too hard to repair. So if someone needs an echocardiogram, they just have to their family has to take them over to the heart center to have that done. And cardiac ultrasound is a pretty basic type of test that, you know, is available in all hospitals in Canada. So it was really, you know, it was really sad to see that they didn't have access to this type of diagnostic procedure. So when equipment breaks, and that's the problem with high tech. And another problem was their ECG machine that they used for the lab that the medical students had. It was also, the paper was, the thermal printer wasn't working. So, you know, what I found is you just have to do the best you can with whatever you have. And technology breaks down, and there's no replacement for it there, so you never want to rely too much on technology. The simpler it is, the more likely it is to be sustainable, because they just don't have the services to fix equipment when it breaks down like we have here. So, you know, the stethoscope is a really useful instrument in Nepal for heart disease. So I don't know how well this projects, but this is a cartoon or artwork that one of the students did, and it shows the mission of Nepal. And I really like this. Like the hospital, so this is a heart, obviously, and on the lower, well, we'll start with the upper left-hand side. You see a little village in Nepal, and there's a man carrying a woman in a basket to the hospital, because, you know, if someone needs health care, they have to be transported on the backs of other people to the nearest health station. And then in the bottom left-hand part of the heart is the Patton Academy of Health Sciences and the Patton Hospital. So hopefully the physicians who are the product of this hospital will be able to make changes to improve health care in rural Nepal. And then it's not just rural Nepal, but there's lots of slums in Kathmandu as well. And on the upper right-hand corner, you see Kathmandu, and the students at the medical school do work in the slums in Kathmandu. But really, we have sort of a global obligation to help as much as we can to improve healthcare throughout the world, because it can come back to us as well through spread of infections and other problems. So the way the medical school is designed, in terms of trying to get physicians to practice in rural Nepal, students enter the medical school at a young age, so direct entry from high school, and students are given preference from rural Nepal. Many of them are on full or partial scholarships sponsored by the government or through donations. And those who are on scholarships are committed, they have to go and practice in rural Nepal after graduation. And then community medicine is a big part of the curriculum. So from the first year, they do rotations in rural villages, and they have a lot of lectures in community medicine. And then once they've been out in practice for a year or two in a rural area, they have priority for residency positions at the Patton Hospital. And they have telemedicine support for physicians in rural areas, because it's really hard for doctors to work in isolation. Like, there's just so much expertise you need to get from other people as well. So telemedicine is very important. It doesn't work well all the time, but that's important for physicians who are in remote areas. So, you know, the lessons I learned from Nepal were just how vigilant you have to be all the time in a low-income country, just to make sure that you don't get sick yourself. Because things that we take for granted here are just not available in Nepal. So you're very likely to get an infection while you're there. You're at risk for all kinds of motor vehicle accidents, especially if you travel around by bus. So life's a lot harder. And there's a lot of things you have no control over in countries like Nepal. You know, there's just, things may happen or they may not. That's just the way it is. We have a much more operational mode of functioning. You know, we set a goal, we develop processes, we use a lot of technology, very goal-focused. Whereas there they have more a relational mode of functioning. So you want something done, you call up a friend, and that friend may know someone else who's able to help you. But it's all done through networks of people. So the social relationships are really, really important. It's the only way to survive in a country like this, because you just don't have access to the technology that might help you out if necessary. But people can make a difference. So, you know, technology for health in low-income countries. First of all, we need a lot more data on the actual disease prevalence and risk factors in countries like Nepal. Very sparse WHO data on health factors in Nepal. And then it's really important to prevent disease. Like, really in medicine, as much as possible, prevention is the most important thing. So vaccinations, a healthy diet with lower fat content, and clean water is really, really important to prevent disease. So you kind of need that infrastructure. And that's what, you know, ideally the technology should focus on. The treatments, you know, they kind of need what I would call low maintenance therapy. So a one-time fix. A very different type of healthcare from what we're able to deliver here in North America. So, for example, an operation that's commonly done in Nepal would be a mitral balloon valvuloplasty. So just opening up a mitral valve with a balloon, because the procedure's done, they reuse the catheters, so it doesn't even cost them very much. And then the patient is much better after that procedure. But any procedure that requires taking medications on an ongoing basis is problematic, because people aren't used to taking medications regularly when they're feeling well. So for example, if you have a mechanical valve in your heart, you need to be on warfarin, a blood thinner, and you need to have blood tests done at least once a month to adjust the dose of warfarin. Well, that's problematic in a country like Nepal. So if they have a mechanical valve, they get the one operation, and if that valve clots off because they're not taking the anticoagulant properly, There's no other options, they die. So it's very different. Simple technologies, because they just don't have the infrastructure to deal with sophisticated technologies that require ongoing maintenance and support. Cell phones are ubiquitous. That seems to work really well everywhere in Nepal, including Everest Base Camp. And it's very inexpensive too. So cell phones are kind of the technology that I think makes a huge difference for people in these countries. So even in this Buddhist monastery, like the monks are on their cell phones. So I thought that was pretty cool. 70% of the world's cell phone subscribers are actually in the developing world. There's just so many more people there. And 90% of the world's population has access to wireless phone signal. So I think simple technologies make a huge difference in people's lives and allow them to communicate and plan better. So, there's obvious benefits to technology, and especially technology that allows you to have access to clean water, sewage management. Like, I have so much respect for sewage management and pollution control after living in a low-income country. And then in terms of health, well, I think vaccinations are extremely important. Maternal health, so that you have healthy children who are born. And diagnosis and treatments of non-communicable diseases, that's pretty expensive, so as much as possible you want to prevent those diseases. But there's disadvantages to technology as well. I'm just really struck by the differences, in Nepal and then in Canada. Technology here, when I walk down the street or I look at people in their phones when I'm biking in the summer, people are so distracted, and they're by themselves in their cars, and they're often on their cell phones, despite the law. They're often, it's like they're not living in the present. Well, people in Nepal, they live in the present. That's really all they have. So there's not the sense of distraction, and technology also gives you the sense that you're self-sufficient, and that your technology will protect you. And I see that in our patients. They think that medicine is somehow going to allow them to live forever. And well, that's just not going to happen. Like, death is a reality of life. And the people of Nepal are much more accepting of that reality. I mean, obviously, I'd like them to live longer, but in Canada, I think we've kind of lost a little bit of that sense of reality. And if you don't recognize that death is inevitable, then you don't live your life as fully. And the people in Nepal, I mean, they have time for each other. They have, the first thing they ask you is, would you like tea? And it's just, there's a closeness to other people that we don't have here in Canada. And I think in part it's our technology that kind of gives us this false closeness to a global world, but we miss out on what's happening right now in front of us when we're just, kind of connecting electronically to other people. The problem with technology in developing countries is that when it breaks down, you can't fix it. So it's just really, you need quite an infrastructure to support high tech, from my observations. And what I really enjoyed in Nepal was the sense of community that is not quite the same here in Canada. So just to finish up, as technology advances, will the gap between the have and the have-nots widen? Well, probably, but I sure hope that the developed countries provide assistance to low-income countries so that they can get some of the basic needs to prevent the infectious diseases that are an ongoing endemic there, and most importantly to prevent the non-communicable diseases that are starting to increase in low-income countries. And why should we help? Well, it's actually in many ways for our own good, because with all the travel between countries, infection, travelers to Nepal, will acquire infections that they can bring back here, and we've seen that with several viral infections that originated in Asia. And then in the country itself, well, terrorism is more likely as social gaps widen. And with the communication that we have now, you know, when something happens at wherever else in the world, we hear about it pretty quickly. It's not so hard to ignore something that you haven't seen yourself, but once you've seen poverty and the needs in a different country, it's really hard to just go back to your old pattern of good living. So I'm just going to end with this statement by Albert Schweitzer, and Arjun Karki uses this all the time when he gives presentations. And I think from my 3 trips to Nepal and the people I've met there, I just feel very privileged to have been able to see how people in a different part of the world live. And you know, some things are very hard in Nepal, but there's also some things that are really good. And I think the best is to take that community spirit and try to develop it more here. And technology, sure, they need some technology in Nepal. They basically need a better infrastructure. So thank you very much for listening, and I don't know if you have any questions.
So I think one of the striking things that differentiates medical care in Nepal and other developing countries is how the physicians tell bad news and what you do about that. It's a very important part of medicine. But I think we, by and large, tend to tell the truth. It's often just not possible for a personal safety thing. It's just like when in a developing country, when you have an accident on the road and you're at fault, it's not that you're going to get into legal difficulties, but people may feel the only way to punish you is if they beat you up right then and there. And similarly, if something's going wrong with a family member, and if you're the physician giving them the news and they don't quite understand the situation, but suddenly they've gotten this very bad news, then it becomes a safety issue for the person telling this bad news. So it's something we really don't usually conceive of here, you know?
No, because we have a more lawful society. Right. And they're kind of lawless, you know, and that's very frightening for physicians. I mean, to think that, you know, when a patient, if you tell the family that the patient is very sick and likely to die, they interpret that as, well, you're just giving up on this family member. And, you know, the families are just so important. It's pretty much all they have, right? So the loss of someone is devastating. And if they feel the system is not helping as much as possible, they can attack doctors. So,
and I think physicians going on strike and kind of job action is also more common there.
Yes.
It's just a whole other way of thinking about the whole relationship between patients, physicians, family.
Yes, it's made me a lot more sensitive to cultural differences here, because, you know, in Edmonton, it's also pretty multicultural, and in certain cultures, like Hindu, it's generally not considered to be a good thing to tell the patient that they have a serious condition that they're likely to die from, because they feel that that would be taking hope away from that patient, and then they're more likely to, you know, die quickly. So in general, and then, you know, I read a little more carefully how it's recommended that we do it here, because generally the way we do it is we tell the patient, you know, what's happening. But it is recommended here as well that we ascertain the patient's readiness to hear that news. And so what I do now is I usually ask, like, are you ready to hear about your condition and what's likely to happen in the future? And do you want me to tell you, or should I tell a family member? And in some cultures, they want you to talk to the oldest son. And so, at least I'm aware that that would be the way to proceed.
Yeah.
So, I've learned a lot. I've learned that, so often we have our perceptions and then we transpose them on everybody around us. And that's just so wrong.
The first semester that we taught this course, it was so dramatic. The story that Dr. Cujec tells about the porter who dies of pulmonary edema, when you think about that, it seems like this is just a terrible tragedy, and there's only one way to think about it. There was an opportunity missed to save that person's life. But Earl Waugh had just been talking about karma and different cultures and reincarnation and the whole idea of the cyclical nature of life that many peoples have. And he pointed out that there's an equally valuable way to think about what happened, which was this was that person's time to die. It was the perfect way to die. He felt his affairs were in order. He asked to be left alone in a certain place. He sort of chose how and where and when to meet his maker, and he probably believed that this was just part of the cycle of life, and maybe the next cycle would be better. And so what Earl Waugh was saying is maybe nothing bad happened. If we had rushed in with Western medicine and treated him, maybe the ultimate outcome would have been less good. So it was probably the first time in this course when I realized how valuable it is to have people in the room with these dramatically different ways of looking at things, whenever you think that there is a situation you've just heard of with only one interpretation possible, you're almost certainly wrong about that. There's another equally good way to think about it.
I still have trouble accepting that, though, because it just seems like, that was a preventable death. And, as we were going down the trail, and, there would be 4 porters who carried the corpse down to Lukla, and then to the man's village. As we were going down, people would ask our guide, well, what happened? And our guide would explain, and, they would have an expression of sadness on their face and acceptance. But then, the villagers gathered around the body in Lukla, and, it's hard on them as well.
Yes.
Who knows what the future could have brought. But it's still hard for a family to lose, their father and their husband.
Yeah. No, I don't criticize that interpretation at all. It's just it's interesting that there is another way to look at it. So.
I just want to talk about this gap of the have and have-nots. It seems inevitable, and this gap is growing and growing. But on the other hand, I like the fact that you talked about cell phones. Cell phones are a very good example of diffusion of innovation in the world. But it's also a very good example showing how technology can leapfrog another one. So in many places, Africa or Asia, they struggled to get the phone lines because building the infrastructure was very expensive due to distance, costs, and so forth. People had to request a phone line in a city and wait for more than a year and hope to get it. And people were celebrating when they got the phone before even it was connected, and they had a party. And then suddenly you have cell phones, and it's spread like fire. Now people can communicate. They didn't dream to do that. maybe there are other technologies that could help people like in Nepal to leapfrog the technologies that we are trying to introduce, and maybe they will catch up in the case of healthcare. Do you think that is a possibility to reduce that gap?
Yeah, I mean, cell phones are just an excellent example of how superior they are to landlines, which were not feasible in a developing country. You know, to me, healthcare is like the icing on the cake. You've got to have a society that's kind of functional. You know, you have to have some laws, some government stability. You can't have bribery. I guess Montreal does. But it's a little different. The extent of bribery in Montreal versus Nepal. It's just like an order of difference. Because people buy positions, right? Like if you want to be vice chancellor of a university, you can buy that position. So it's very different. And then, you know, how all the medicine in the world isn't going to help if people keep getting infections because the water's contaminated. So I think I'd like to see like technology that's going to improve basic needs. And I'm not sure exactly, you know, other than like engineering and just a better infrastructure. I think we have the technologies available to improve that. But I mean, when I look at Nepal, I just see bad government, you know? That's the basic problem. And I don't know how that's going to change other than having more of the population educated. And right now what's happening, a lot of the educated people leave Nepal. Like, you know, the best of Nepalese have left the country. They're probably in the United States, right, or some in Canada, and other countries where their economic futures are better. So there has to be enough educated people who stay in Nepal and make it a better country. And then I think things will change. I don't know, do you have any comments on that? I mean, I think technology is great, but you kind of have to have a foundation that I don't see in Nepal.
We're out of time, but thank you very, very much. 400 students going to descend on us here, so we have to get out of the way.